particular chapter of journal Pathology in Robbins. Okay. Now, shockingly, the shock lecture tomorrow should have been next week. Okay, I can remove this now. I'm pretty far away from you guys. Don't worry. It's more than 6 feet, and I will stay here. So I'm not infected either, inshallah. Hopefully. But because your PBL cases last week and this week were on shock, so they have asked me to move my shock lecture to tomorrow, which was usually the last lecture, because in the chapter, you will see that it goes in that fashion. Okay, we will start with the name of the chapter is, by the way, hemodynamic disorders. All of them are related to hemodynamics, right? Now, these are the objectives. We will be discussing the definitions of hyperemia, congestion, and hemorrhage. We will discuss the definitions of edema, and we will discuss 4 major mechanisms of edema and 1 minor mechanism of edema as well. So total 5 mechanisms of edema. We will discuss 1 cause of edema as an index example for each mechanism. Okay, for each mechanism, we will discuss 1 example or maybe more than 1 example. And then I will give you some clinical correlates related to edema and its presentations. Okay. Yeah, I just want to see that my screen is being shown. Okay. Now let's start with the definitions. The first definition is hyperemia, and the second one is congestion. Hyperemia and congestion. Okay. Hyperemia, number 1, means increased flow of blood. Congestion means increased backup. Hyperemia is an active process. Congestion is a passive process. Okay. What do we mean by active and passive? It means that hyperemia happens when there is increased blood flow to an area where the blood supply is. Okay. So maybe it can be physiological. Physiological means after exercise, you know, some of you, mashallah, are going to the gym and they're exercising and their veins, they really swell up. That's an example of hyperemia. Why? Because there is increased blood flow that is going to that area that we have just exercised. Okay. So, and this is an active process. So this example is physiological. On the other hand, and you just recently completed with Dr. Abrar the lectures on acute and chronic inflammation. So in acute inflammation, is there vasodilation? Yes or no? Yes. There is vasodilation. So if vasodilation is happening, would the blood flow increase? That would be an example of hyperemia. And that's this, and this one that says inflammation is an example, okay? A pathological example. So I've given you 2 examples of hyperemia. One is physiological and one is pathological. So far, so good. So hyperemia just means increased flow to an area, okay? Active process can be physiological, can be pathological. Congestion is secondary to an obstruction, okay? So it is basically, there is decreased outflow. And because there is decreased outflow of blood, it can be local, it can be general. So local obstruction, if there is a local obstruction at any area, the blood cannot flow out, right? If the blood cannot flow out, there will be congestion of blood in that area. We use that in common language, there is congestion of blood, okay? Also, it can happen after heart failure. And that's why we call it congestive heart failure. See the word congestive heart failure, because it leads to congestion of blood. And we'll be discussing that, the congestive heart failure, as an example of edema formation in detail today. So once again, the definitions are hyperemia and congestion. Hyperemia is an active process, congestion is a passive process. Moving on. This is an example of hyperemia. This patient, which leg is affected? That one or this one? Oh, this one. Good. I just ask sometimes questions just to wake you guys up. Okay, and very simple questions. I hope you do the same. Okay, so this one is showing congestion. Maybe it's secondary to an infection in the leg, cellulitis, etc. But we can see that the blood is all pulled up here, right? So there is an increased flow of blood to this area, and what we call it hyperemia. Okay, this one is normal. Okay, this is an example of congestion. So some people in the olden age especially will develop something that is known as varicose veins. Okay, in varicose veins, what happens is that the walls of the vein, they are not functioning. They're not functioning properly. So these muscles and the veins cannot pump blood back to the heart, and the blood will get pooled over here, and that is going to lead to congestion. So this is an example of congestion. Remember in the previous picture, the picture was red. Over here, the picture is blue. Why? Because that was arterial blood and this is venous blood. Why? Because the problem is in the veins. Understood? Easy? Moving on. Now, this one can happen also in congestive heart failure in some patients, not in all patients. It can happen that in congestive heart failure, there is passive congestion of the liver. There is chronic. Chronic means it is happening for a long time, and the blood, it pools in the liver. When it pools in the liver, it gives rise to this very characteristic morphological appearance. We call it the nutmeg appearance. Nutmeg. Have you seen a nutmeg? Yeah, that picture is not of a liver. That is the picture of a nutmeg. Okay. That picture is that of a nutmeg. I even translated it for Arabic for you guys, and you call this. What is this? Good, that thing. Okay, and by a wide imagination, like you really have to expand your imagination, and if you do, and train your eyes to see this, you can see that there is some similarity between this appearance and this appearance. Okay. I'm not going to force this on you, but if you expand your imagination, you may say, okay, if Dr. Raihan is saying this one matches with this one, we will accept it at face value. Okay. Now, when do this happen? It happens in, what is the cause? Congestive heart failure. What does it lead to? Chronic passive congestion in the liver. What is the morphological appearance? We call it a nutmeg liver. Why do we call it a nutmeg liver? Because it looks like a nutmeg. What is a nutmeg? It's a type of nut. Understood? Easy enough? Okay. What actually happens is this. There is, when we see on the gross examination, they are red, brown, and slightly depressed owing to cell loss, hepatic lobules, which are accentuated against the surrounding zones of uncongested tan. So this is the basic mechanism. The liver lobules have blood and the surrounding areas does not have blood. So this is leading to congestion. And when this congestion happens over a long period of time, it can lead to this morphological appearance. Clear? The cause, remember the cause. If you see this in an OSPE or in any exam, the cause will be congestive heart failure. Appearance would be, okay, inshallah you will remember. Moving on. Then we come to hemorrhage. What is hemorrhage? Hemorrhage is bleeding beyond vessel, right? Extravasation means bleeding beyond vessel. Blood, when it comes out of the vessel, we call it hemorrhage. Some patients, so everybody bleeds, and I've told you this before in the blood block, though, and when I refer to blood block, I really don't mean that you would remember anything from that time. That is not how the things work. You may have good memories about it, you may not have good memories, so we're not going there. But I have mentioned hemorrhagic diathesis before, and I will be repeating that today. Everybody bleeds after trauma, right? Right? But some people, they would bleed without trauma or bleed excessively after minor trauma. If they do, we call that a hemorrhagic diathesis, a tendency to bleed. Hemorrhagic diathesis means a tendency to bleed either without trauma or excessive bleeding after minor trauma. Understood? This is the definition of hemorrhagic diathesis. Hematoma means collection of blood in a cavity. It implies a mass effect. Okay, so hematoma can form in the abdominal cavity, collection of blood in the peritoneum. It can be in the joints. If it happens in the joints, we call it, anybody? Hemarthrosis. Okay, now there are three definitions more. One is petechial hemorrhages. Petechial hemorrhages are a small bleeding, less than 3 millimeter, secondary to a problem with the platelets. Either there is thrombocytopenia, platelets are low, or they're not functioning normally, and that is going to lead to bleeding in the subcutaneous vessels, and we call that petechial hemorrhages. I will show you a picture on the next slide. If they are slightly bigger, we call them purpura. If they are less than 1 millimeter but bigger than petechiae, we call them purpura. And if they are really big, more than 1 centimeter, we call them a bruise in English or ecchymosis in medical terminology. Okay, so these are three more definitions: petechial hemorrhages, purpura, and ecchymosis. All of them are secondary to bleeding. Okay, usually petechial hemorrhages and purpura are secondary to a platelet problem. The only difference between the three of them is the size. The size is different. Petechiae are really small, like mosquito bites. Okay, purpura are bigger, and ecchymosis are more than 1 centimeter. The bleeding can be acute and chronic, and it can be in thorax, in pericardium, in peritoneum, in joints. And when it happens in respective places, we just add the word hemo. If it happens in the thorax, we call it hemothorax. If it happens in the pericardium, around the heart, we call it hemopericardium. If it happens in the peritoneum, we call it hemoperitoneum. And if it happens in the joints, we just add the word heme, and it becomes hemarthrosis. Easy? Any problems? Any questions? Moving on. Okay, these are the pictures for petechial hemorrhages. These are not mosquito bites, guys. These are petechial hemorrhages. These are subcutaneous vessels bleeding due to a platelet problem. Why are we calling them petechiae? Because they are very good, small in size. What about this one? This is not small. This would be a, okay. These are conjunctival petechiae, bleeding happening in the conjunctiva. Okay, see this? This one. Patient can bleed from anywhere, wherever the vessels are. This is an example of bruise or ecchymosis. Why are you calling it ecchymosis? Because it is really big. I think if we turn off this light, it will be even clearer. Can somebody turn off that light, the front light? Because I don't, anyway. Moving on. And that completes our portion of lecture concerned with the definitions. Okay. What is edema? Anybody have any idea about edema? What is the definition of edema? Fluid. Accumulation of fluid in the, yeah, it's written right here. I'm not asking, you just have to read this. So can you go ahead?
Okay. Edema is the mobile excess of fluid in the interstitial tissue or inside cells.
Excellent. So it is an accumulation of fluid in the interstitial space. Mostly when we talk about edema, this is the definition that we are referring to. It can happen inside cells. It's called hydropic change in medical terminology. I'm not going to go there at all. It's not going to be covered. Okay. But mostly what we'll be talking about is an excess fluid accumulation in the interstitial tissue. And I think all of you know there are two kinds of edema. One we call a pitting edema, and the other we call a non-pitting edema. Okay. Pitting edema means if we press on the shin, on the lower limb for around 20 to 30 seconds and we remove our thumb, it will lead to the formation of a pit. Okay, so if a pit forms, we call it a pitting edema. See how simple. Pit is forming, we are calling it a pitting edema. Okay, hematologists are really simple people. We see a thing, we just call it that thing. Then the non-pitting edema means we will press it, but the pit will not form. If the pit will not form, what do we call it? Non-pitting. Okay, can anybody in the class give me an example or a cause of non-pitting edema? I will give you a hint. Not that you need a hint. MashaAllah, you are geniuses and intelligent people. But I will give you a hint. The question is related to your endocrine block, which you did this year, right? Hyperthyroidism, right? Very good. And do you remember? That was one of the cases, one of the PBL cases as well. Apart from the fact that it was covered by multiple lectures, right? And do you remember what was that one? Pretibial myxedema is excellent. Excellent answer. Very good. And this is the last type of edema which is going to come at the end of the lecture. Now that he has mentioned it, do you remember it? Do you recall that?
Yes.
Okay. There are 5 people saying yes. What are you talking about? Okay. Now this is something that you may have done previously under cardiovascular block. The next 10 or 14 slides are from that area. So, and we call it them the Starling's laws, and we will be discussing that usually this is the arterial end, and this one is the venous end. Okay, this is the arterial end, and this is the venous end. On the arterial end, we have something that we call hydrostatic pressure, which is just like blood pressure, but we call it the hydrostatic pressure. And usually at the arterial end, it is high, and it is about 35 millimeters of mercury, whereas at the venous end of the capillary, it is less, it is around 18 millimeters of mercury, okay? Then we have another pressure that we call osmotic pressure. Osmotic pressure, and this osmotic pressure is exerted by the presence of proteins in the plasma. The most important protein is albumin. See, all of you know that. And because the amount of albumin at the arterial and at the venous end is the same, So that's why the osmotic pressure of capillary is the same. It is around 25 millimeters of mercury at the arterial end and the same at the venous end. Okay. So if we subtract 25 from 35, the difference over on this side is around 10. And on this side, it is around 7. So 10 minus 7 is that as compared to the arterial end and to the venous end, there is a difference of 3 millimeters of mercury. That means slight amount of fluid will go out of the capillary bed, very slight amount. And to clear away that fluid, what do we have? We have the, what do we have? The lymphatics, right? We have the lymphatics. So you all know this concept, right? So we have hydrostatic pressure, which is higher at the arterial end and slightly lower at the venous end. And we have the osmotic pressure. And the interplay of edema happens because this difference is around 3 millimeters of mercury. And that will lead to some excess fluid coming out of the vessels, which will be cleared up by the lymphatics. Okay. Now, if we understand this concept, we can on our own, if we just think about a little bit, we can on our own come up with different mechanisms of edema. Okay. So the first thing that can happen is increase in the hydrostatic pressure. The hydrostatic pressure can go up. The second thing that can happen is this, the osmotic pressure of the capillary, it can go down. Okay. Because the proteins are responsible for keeping the fluid inside the vessel. If the proteins are down, then the osmotic pressure will go down. So things like hypoalbuminemia due to any cause. Okay. What is the third cause? Okay, so there is something wrong with the lymphatics. Something wrong with the lymphatics, lymphatic obstruction or lymphadenitis or lymphadenitis, things like that. Anything wrong with the lymphatics can also lead to edema. And what is the fourth cause? Increased capillary permeability. So if this capillary endothelial lining gets damaged due to any reason, that will lead to the fluid escaping from inside the vessel to outside, extravasation of from inside the vessel, inside the capillary to outside. So that is the fourth mechanism. So these are the only four mechanisms you are supposed to know. Increase hydrostatic pressure, decrease osmotic pressure, increase capillary permeability, and lymphatic obstruction. Agreed? And you yourself gave me this. The only reason this one is in red is not because it's going to come in the exam or it's important. Because when I put it in black, because of the black thing behind it, it wasn't appearing up very clearly. Moving on. So let's discuss one by one increase. Give me a couple of causes of increased hydrostatic pressure. Just what? Yeah, go ahead.
Maybe hypertension.
Hypertension. Okay. What will chronic hypertension lead to?
Ventricular hypertrophy.
And what will that lead to? Keep thinking more and more.
Heart failure.
Heart failure. And what kind of heart failure would that be? Congestive? We just discussed, remember? Congestive heart failure. Okay. And think of, so can anybody think of one more thing? Otherwise, if you just press down, the answers are right there. You have the presentation in front of you. Sorry? Kidney failure. So anything wrong with the kidneys will also do that. Okay, let's take a look. What can cause increased hydrostatic pressure? Kidney failure. So in renal failure, that is going to lead to increased water retention, and if more water is there in the body, that will increase the hydrostatic pressure. Hyperaldosteronism. What is the function of this hormone, aldosterone? What does it do? It conserves sodium. It conserves sodium. It prevents sodium from going out. And if the sodium cannot go out, it remains in. What else will not go out? Water. So sodium and water, they go together. So that's why in hyperaldosteronism, same mechanism, it is going to lead to more water retention, high venous pressure, heart failure, venous obstruction, and failure of venous valves. The most important cause of increased hydrostatic pressure is heart failure, congestive heart failure. And we will be discussing this in detail today, inshallah. Okay, so far so good? Okay, let's discuss congestive heart failure. I'm sure you know all of these concepts, but because the congestive heart failure leads to a generalized increase in the venous pressure, and this leads to resultant systemic edema. Therefore, this is the most common cause of edema due to increased hydrostatic pressure. Overall, there are two main effects. Number one, increased central venous pressure. Number two, decreased renal perfusion. Number one, increased central venous pressure. And number two, decreased renal perfusion. Now what happens is heart at the pump is filling, and that will lead to decreased cardiac output. So heart is not pumping out enough blood. That will lead to increased backup. So blood will back up first into the lungs, then into the venous circulation, and this will increase the central venous pressure, and that will lead to increased hydrostatic pressure. So heart has failed, it is not pumping blood. So the blood will first back up into the lungs and then into all the venous circulation, and this will increase the hydrostatic pressure. Then, this is the first mechanism. Then this congestive heart failure also leads to decreased cardiac output and less arterial blood. Okay, it's not pumping blood. So the kidneys, they don't see enough blood coming through. Kidneys don't see the blood. It doesn't see the blood that is coming, that was supposed to be coming, but it's no longer coming because heart is not pumping enough blood. Okay. So then what happens that because there is decreased renal perfusion, the renal defense mechanisms will get activated. And these are the renal defense mechanism: the renin-angiotensin-aldosterone system, renal vasoconstriction, and increased secretion of the antidiuretic hormone. All three of them, as you already know, will lead to more water in the body. Okay, and that will lead to increased hydrostatic pressure, and that will lead to edema. Okay, all three of them are going to do the same, all three things. Antidiuretic hormone, as the name indicates, prevents water from going out. Aldosterone, we just discussed, will prevent sodium from going out, and that will lead to more water inside the body. And renin will increase the, what does renin do?
It's an enzyme that converts angiotensinogen into angiotensin 1.
And then what happens?
Then angiotensin 1 goes to the epithelium in the lungs and gets converted to angiotensin 2.
Very good.
By ACE enzyme.
And then what happens? What does angiotensin do?
Increases aldosterone secretion.
Okay. And does it lead to renal vasoconstriction?
Yes.
Okay, thank you. So this increased central venous pressure, decreased renal perfusion leads to increased ADH, increased renin, increased renal vasoconstriction, and all of this together will lead to increased hydrostatic pressure, and the patient will present with edema. Okay, usually lower limb edema, bilateral lower limb edema. And what kind of edema would that be? Pitting or non-pitting? Pitting. That would be pitting edema. Okay. Remember, the non-pitting edema, the only cause was what he mentioned, petechial mixed edema. All the rest are pitting edemas, mostly. Okay, second cause, decreased osmotic pressure. Can you give me a couple of examples that can lead to decreased proteins inside the body? That liver failure, liver cirrhosis, same thing, very good. And again, something wrong with the kidneys. Can you name that? Nephrotic syndrome. What did you say? Sorry. Loss of proteins secondary to nephrotic syndrome, for example. You're absolutely right. Very good. So decreased plasma proteins can happen because of loss of protein in the urine, nephrotic syndrome, loss of protein via burns or wounds, failure to make proteins because these proteins, albumin and globulin, they're all produced from the liver. And if the liver becomes cirrhotic, meaning it's shrunken in size and it gets fibrosed, it will not produce albumin. It will not produce anything. It will also not produce albumin. And albumin is the main protein that exerts the plasma oncotic or plasma osmotic pressure. Okay, so that will lead to decreased plasma oncotic pressure, and this can lead to edema again. Now, previously, or even in some areas of the world, if there is serious protein or chronic malnutrition, that can also lead to decreased plasma oncotic pressure, leading to edema. Okay, these are all very simple causes. So albumin is the protein most responsible for the maintenance of osmotic pressure. A decrease in osmotic pressure can result from increased protein loss or decreased protein synthesis. Increased albumin loss can happen in nephrotic syndrome, which is secondary to the increased permeability of the glomerular capillary wall. So more and more proteins are lost every day. More than 3 grams of proteins are lost every day in urine in nephrotic syndrome. There can also be reduced albumin synthesis, for example, in cirrhosis of liver or in protein malnutrition. All of them leads to reduced plasma osmotic pressure, and then this can lead to edema, right? Okay, more than one cause can also exist in a patient. More than one cause. A combination of causes can also exist in a patient. So they can have increased hydrostatic pressure and decreased plasma osmotic pressure. For example, in a patient who is suffering from congestive heart failure plus liver failure. So both the causes can be present in a single patient. Okay, let's go to third one. What can cause increased capillary permeability?
Chronic inflammation.
Why not acute? Acute. Bacterial infection would be the first one, isn't it? Chronic inflammation can cause, like tuberculosis, etc., but think of the bacterial infections first. So any kind of immune reaction that release histamine. Remember histamine from acute inflammation? That was in this block. That's pretty recent from Dr. Bra. So acute inflammation, any cause that he has discussed, appendicitis, etc., everything can lead to increased capillary permeability, and that can lead to edema, either local or generalized, depending where the inflammation is or how much of that is an inflammation. Toxins coming from the bacteria, bacterial infections, and burns, they can all increase capillary permeability. Look at burns. Is this the only mechanism burns is going to cause edema? There are more than one mechanism in burn, right? So what are the two mechanisms? One is increased capillary permeability, the other is loss of protein. Okay, so that's another example where more than one mechanism is responsible for causing edema. Very good. Okay, let's see. The fourth is lymphatic obstruction. Lymphatic obstruction can happen secondary to anything that affects the lymphatics. So in cancer, we have many kinds of cancer, but there is one special kind of cancer that involves the lymph nodes. Okay, and that is known as lymphomas or lymphoproliferative disorders. Lymphoproliferative disorders or lymphomas. Okay, I understand you have not taken neoplasia lectures, which are coming up later, but you can remember one or two words. Now this affects the lymph nodes, and once the lymph nodes gets affected, then this will lead to lymphatic obstruction and the excess fluid will not go out. This is usually leads to localized edema. Then there is an infection known as filariasis. This filariasis is due to this organism known as Wucheria bancrofti. I will show you a picture. It leads to elephantiasis because this organism destroys all the lymphatic vessels in the lower limbs, and that leads to elephantiasis. Localized edema usually can be unilateral, can be bilateral, depending upon the amount of infection. So some patients, they may undergo, they may develop females especially, but it's not like breast cancer is not there in males. It can happen in males, but less common. So females who undergo breast removal surgery, we call it mastectomy, radical mastectomy. If we remove the breast, we also remove their lymph nodes. And when we do that, because the lymph nodes and the lymphatics, they are all removed after surgery in breast cancer, this can lead to localized edema around the breast. Okay, and there is a special name for it. Let's go to that. So impaired lymphatic drainage will result in lymphedema, usually localized, usually due to inflammation or neoplastic obstruction. This is an example. This is secondary to Wucheria bancrofti. We call it filariasis, and this thing is known as elephantiasis. So this organism has destroyed the lymphatic vessels in the lower limb, and that has led to localized edema. We call it filariasis. What is the name of it? Oh, you don't need to remember the name of the organism, but remember the picture is showing filariasis, and the appearance is known as elephantiasis because the legs, they look like the legs of an elephant. Okay, terrible infection. Now, in the neoplasia or cancer, if we remove the axillary lymphatics in breast cancer patients, that can lead to arm edema, and obstruction of the superficial lymphatics can lead to edema of the breast skin, and we call it orange peel appearance. That was the picture, or in French, we call it this. Anybody knows French? Anybody speak French? Nobody? Okay. The correct French pronunciation is different from what I'm going to say now. I'm just going to say Pure de Orange, but that's not the correct pronunciation. In French, it is pronounced differently. It will be more like Hood Orange, something like that. Okay, but you get the picture. Okay, and look at this picture. This is a picture of localized edema around the nipple in a breast cancer patient who has undergone radical mastectomy, leading to this orange peel appearance. See this appearance? This is like an orange peel or Hood Orange. Usually, when in the class, there are always one or two students who can speak French, and then they oh, you can? Yeah, that one. See? Did you hear? Can you come here and say it in the mic, please? Because there are like 100+ students online. They didn't hear you. Guys, wait. One student is coming to tell you the correct pronunciation. We are almost at the end of the lecture anyway. Okay, go ahead. What's your good name? Noof? Yeah, Noof is going to tell you the pronunciation for this. Go ahead. Say it in the mic.
Peau d'orange.
See? So impressive. Thank you, Noof. Okay, moving on. If there is generalized edema all over the body, we call it anasarca. The word that we use, if there is generalized edema all over the body, we could say it anasarca. Anasarca is the medical term that we use for generalized edema. For example, in this fetus who was born dead, he had an immunological problem that led to his death, and he had generalized edema all over the body. So we call it fetal anasarca. Now, the collection of fluid can happen anywhere in the body. This edema, the 4 mechanisms that we have just discussed, it can lead to collection of fluid anywhere in the body. But we don't call it edema. We use other terms to describe it, although the mechanisms is what we have discussed so far. So if there is collection of fluid in the peritoneal cavity, we don't say there is edema. That is a wrong way of describing it. What do we say? We say that the patient has either peritoneal effusion, or the correct term is ascites. Ascites. Okay. So this thing can happen. And then let me give you a couple of more examples, and then I will discuss it further. Collection of fluid can happen in between the pleural membrane, right? And we call it pleural effusion. What do we call it? We call it pleural effusion. We don't say it's edema, although the mechanism is edema. The mechanism that we have discussed, but we don't say, oh, the patient is having edema in the lung. We can say if it is inside the lung, but when it is collection of fluid in the pleural cavity, we call it pleural effusion. Okay. Same goes for pericardial effusion, that is collection of fluid of blood around the pericardium. We call it pericardial effusion, although the mechanism is the same. So let's discuss this a little bit more. What we can do, and maybe you know this from Dr. Broad's lecture, if you take a needle and we did a peritoneal tap, it is one of the most simple procedures that you can do. You just take one syringe, you put it in the abdomen, just like that. If it is this much, and before you do that, you make sure that it is not fat and it is collection of fluid. Okay, that's really important. You can get slapped. So, and then you take out the fluid. So you can do a peritoneal tap. You can do a tap from a pleural effusion. So you take a look at the fluid, and then you also do its chemical and other examination under the microscope and in the laboratory. And you need to decide whether this is an exudate or it is a transudate. Okay, have you heard these words from Dr. Brown? Okay, great, excellent. So what's the difference? What is the main difference between a transudate and an exudate? Protein concentration and cells. These are the two main things, proteins and cells. So the protein is going to be high in exudate and cells are going to be high in exudate. Proteins are going to be low in transudate and cells are going to be low in transudate, right? Am I right or wrong? Okay, great, thank you. Okay. So if the proteins are high and the cells are high, that means that the underlying mechanism can be infection. It can be an acute infection, secondary to pneumonia, for example, happening in the lungs, or it can be secondary to, because the infection is going to lead to increased capillary permeability, and that will lead to the fluid escaping it. But when the fluid is escaping because of increased capillary permeability, it will take the fluid will have increased protein and increased cells, because this is because of increased capillary permeability. Usually the proteins and the cells cannot escape. But if there is increased capillary permeability, the cells and the protein will all escape. And that will lead to an exudative appearance in the fluid. Do you get it? But in congestive heart failure, is there increased capillary permeability? Yes or no? The answer is no. Why is there fluid escaping? Because of increased hydrostatic pressure. So the pressure is high, the hydrostatic pressure is high, but there is no increased capillary permeability. That means that the fluid that is escaping will not have two things. It will not have proteins and it will not have cells. So what will be the appearance of the fluid? Transudate. Do you understand this now? So I'm trying to tie in these concepts with what you have learned in acute and chronic inflammation. Okay. One more thing. How can we tell? We can tell by just looking at the fluid. If the fluid is clear, watery, straw colored, it is more likely to be a transudate. If it is murky, cloudy, or dark in color, it is more likely to be exudate. Then we do microscopy and we do chemical analysis. If the cell count is high and the proteins are high, we will say it is exudate. And if the cell count is low and the protein is low, we will say it is transudate. Why is that important for you as becoming physicians and doctors? Because based upon this, you can direct your investigations to find out the cause in the right direction. And that is the purpose of these lectures, to take the basic concepts that you have previously learned in physiology and then apply it in pathological conditions. Okay, so develop your mind by thinking about what is happening, the mechanism that we have discussed in the context of clinical situations, because that is the way the MCQs will be coming. I'll be giving you clinical scenario and I'll be asking you what is the most likely mechanism of edema. This is how my mind works. It will, from my questions, will mostly be clinically oriented questions. They will not be simple recall. Based upon the examples that we are discussing right now in the class. Everybody understood these concepts of transudate and exudate and how these concepts are related to the underlying mechanisms of edema? So you understand that? If somebody, okay, great. If you have, it's fine. Okay, let me give you, I have 2 minutes more. I will take 2 minutes more. Let me give you one more example. If somebody, because he mentioned chronic inflammation, do you know about tuberculosis? Have you heard this word? What happens in tuberculosis? Sorry? Okay. What happened? You're right. You're not wrong. You're right. What else happens? Granulomas. What else happens? It invades the lymphatics, right? And it obstructs the lymphatics, right? So, and it will lead to increased capillary permeability because it's a bacterial infection. And because of lymphatic obstruction, there can, if it is abdominal TB, there can be ascites or peritoneal effusion. So if you did a tap, a peritoneal tap, the fluid is going to be exudate or transudate? Right. Good. If you understood that, then you are okay. What kind of cells will it have? Neutrophils or lymphocytes?
I think it depends.
Lymphocytes. It's a chronic inflammatory disorder. Always in chronic inflammation, the cell is a lymphocyte. In acute, it's neutrophils. Remember that this is very important. Okay, moving on. Okay, pulmonary edema may cause death by interfering with oxygen carbon dioxide exchange, creates a febrile environment for infection. Brain edema can happen secondary to trauma, abscess, brain tumor, infection, for example, encephalitis due to any infection. The problem is there is no place for the fluid to go, okay, in brain edema. And then that is going to lead to herniation of the brain. It can lead to increased intracranial pressure and finally death. So the mechanism is still the same that we have so far discussed. In this case, if it is an infection, the mechanism will be increased capillary permeability. The fluid is coming out, it has nowhere to go, leading to increased brain herniation, increased intracranial pressure, and if you don't treat it with antibiotics, if it's an infection, or other mechanisms, if it is cancer, then the patient can die. Okay, I think, okay, this is the last one, which is another mechanism of edema. It is due to increased synthesis of extracellular matrix. We call them glycosaminoglycans, synthesis by fibroblast. Example is pretibial mixed edema that happens in Graves' disease. This is the fifth and the final mechanism. Okay, but the more common one, this will lead to non-pitting edema, by the way. But the more common ones are the 4 mechanisms that we have discussed so far. Okay, this is chapter 4, Robbins Basic Pathology, 10th edition. Those of you who are fond of studying from books, this is the chapter that we are following for these 4 lectures. Okay, any questions, guys? Thank you. You have 14 minutes of break before your PBS.